So thank you very much for inviting me to in the first annual advanced interventional course. Today my topic is adult congenital heart disease. I am Dr. Sattar, Shaikh, consultant congenital heart disease in ICUD. So you know the congenital heart disease basically is a severe type of disease that can present from the neonatal life to the adulthood. And if we can see the burden of the congenital heart disease from the total defect is around 24 to 25%. And out of these, in the Pakistan, every year 50,000 to 60,000 babies are born with congenital heart disease. Out of them, around 35% remain undiagnosed and present in the adulthood or adolescent. Otherwise, 25% in other population that is referred late. Can diagnose at early age, but referred late due to multiple reasons. We are not going into detail. Here we can see the changing proportion of adult and pediatric congenital heart disease in developing countries. Initially, during 1965, you can see that 30% population were adult patient and 70% were the pediatric population. But with the progression of time, advance in the technology, their survival improved. And now currently you can see the population, this is the US data. The population, total population, you can see the 60% are the adult patient with congenital heart disease, mostly they are operated and surviving their adulthood. And only 40% are the pediatric population. How they develop this proportion from pediatric to adult? Because of the advance in technology, early diagnosis, early referral, and proper treatment. You can see initially it was 24% survival in 1950s. That improved to 90%. Only by simple early recognition, proper counseling, proper education, awareness, timely referral, and appropriate management. So survival improved. They are living in the adulthood and living as a normal life. In ICUD data, you can see before the Sattar centers, our adult portion, unoperated patient in the congenital heart disease were almost 61% was unoperated adult patient. But after the Sattar center, this proportion changed. Now almost 2/3 patients are operated or treated, and they are coming in the adulthood or adolescent age. And how we change this pattern? We started the pediatric services or congenital heart disease clinics at the all Sattar centers. We enrolled all the adolescent and adult patients in our clinics and started their treatment, intervention, and surgeries. Now they are living the normal lifestyle, normal pattern, and their survival is almost equal to the normal population. But still 29% are the unoperated, or these patients are the new patient, or these patients are in the stage where they are unoperated, unoperable, or we can say in advanced stage. So still we have a lot of the burden of adult congenital, unoperated, or advanced stage patient. Adult congenital heart disease is not a disease, it's a syndrome. Once it's developing the complications, mostly heart failure, cyanosis, Eisenmenger, it will affect all the body organs. And patient will be living in the miserable life with heart failure, dependent life on the family, society, or healthcare system. What are the most common diseases that are present in adulthood? These are the VSD, ASD, PDA, coarctation, AS, and pulmonary stenosis. Almost 2/3 patients belongs to these pattern. Here we can see if we are diagnosing at the early age, their survival will be like 90% up to 45 years of age. And this is possible for these all type of cases. But if we are addressing these patients and operating these patients at early age, if we are addressing and operating these patients at the late stage, their survival is very poor. Which patient is a high risk of suspicion for the adult congenital heart disease? Any patient who is presenting with murmur or cyanosis, failure to thrive, repeated chest infection, or has had the history of congenital heart disease in family, sibling death, a patient is syndrome. Like the most common syndrome, Down syndrome, Turner syndrome, Noonan syndrome, always screen these patients. Even they are the adult, they may be misdiagnosed or undiagnosed due to minor type of problems. Or any patient who is coming with a cardiomegaly, pulmonary edema, or oligemic lungs with a board shape. So most common in disease that is present in adulthood is the ASD. ASD, you know, is a defect in the intratracheal septum. It's a multiple type like primum, secundum, coronary sinus type, ISVC, SVC type. So this most common is the ASD secundum that is present at the fossa ovalis. So any defect at fossa ovalis is the ASD secundum. You can easily diagnose, easily recognize. They will present with a few minor symptoms. If it's a small defect, there will be no symptoms. Only incidental finding of murmur and fixed splitting heart sound. If a large defect, there will be raised JVP, RV heave, systolic murmur, fixed splitting, and if a patient is developing the ventricular dysfunction, then there will be a JVP raise, epigastric pulsation, and hepatomegaly, and signs symptoms of right heart failure. On ECG, you can easily diagnose the ASD by the RSR pattern and incomplete right ventral branch block. If in advanced stage of ASD, there will be a pulmonary plethora, prominent pulmonic artery knuckle, and right ventricle atrium dilatation. So any patient who is present with a prominent knuckle of the pulmonary artery with a pulmonary plethora, think about the any left right shunt, mostly the ASD. So in the echocardiography, you can easily diagnose different type of septal defect. Like in the upper portion, you can see this is the PFO, simple with the flap. In this portion, you can see this is the not ASD, this is the aneurysmal interator septum with fenestration. So this is a more complicated disease. You cannot diagnose by simple the transthoracic echo. You need the transesophageal echocardiography or at least the other advanced modalities. And if any aneurysm interator septum, you have to work thoroughly for the closure of the interator septum, because this aneurysmal septum will produce some sort of thromboembolism, will be a cause of the thromboembolism, and sometimes may lead to the early right ventricular or left ventricular dysfunction, depend upon the fenestration. Other things mostly presenting is like the ASD secundum. So in the echocardiography, you can see this is a multiple fenestration, 3D multiple fenestration, and this is on the table. You can see multiple fenestration. So these multiple fenestration, mostly interventionist cardiologists think this is not deviceable, but you can close it with device. There's a special device known as the cribriform device. So you can close multiple defect by the two devices. So here you can see sometimes we are misdiagnosed, miscalculating the size of ASD by taking the size from the eustachian valve. So you have to check the appropriate where the IVC rim or atrial septal alignment. So if you are taking this eustachian valve, it's a prolonged, you can misdiagnose or size the ASD. And if you are trying to close with a device, then it will be dislodged easily, because this is not a septum, this is a eustachian valve. Other things is a Chiari malformation. This is against the, you can say, the normal morphological type of network. And if this is present, it will make your device closure mostly problematic. Sometimes the displacing the device or making it's a malaligned device. So when to close the ASD, any patient with the RA-RV enlargement, and if sign symptoms present, it's a class 1, if sign symptoms not present, then still you have to close this a class 2 indication. But think about the pulmonary hypertension. Any patient who is with the pulmonary hypertension on echocardiography, check by the cardiac catheterization to see the compliance, proper QPQS and PVR, SVR ratio, and also check the left ventricular and diastolic pressure. Because in the adulthood, our RV and LV compliance is not good in the case of atrial septal defect. Mostly the left ventricle, because left ventricle is undervolumed. Most of the shunt is going from the left atrium to right atrium, and LV is remain depleted. It is getting decreased volume, so its compliance will be less. Once you are closing the ASD, you are giving the all volume from left atrium to left ventricle, it will not compensate your whole volume. So EDP is already high, it will produce the left ventricular dysfunction, pulmonary edema, and patient will be in the crisis during on the table or immediately after the procedure. Again, you have to check what the cerebrovascular accident, atrial fibrillation, and pregnancy. These are the high risk. So guidelines are already clear. Natural history is that ASD, if small, it will be closed spontaneous. If moderate to large, it will progress with time. So any ASD who is a moderate to large, you have to follow. Indication normally is you have to close the ASD before school going age. Or whenever patient is diagnosed for the ASD, you have to close, irrespective of the sign symptoms. If only RA-RV enlargement present, RA-RV volume overload, you have to close the ASD. Otherwise, pulmonary hypertension will develop, or atrial fibrillation will be developed in the 4th decade of life. Once atrial fibrillation and pulmonary hypertension develop, it means you are in the advanced stage. Patient will give you a tough time during the procedure, whether device or intervention. It will develop the consequences of ventricular dysfunction, arrhythmias, low cardiac output, not during the surgery or device, even their long-term of life. So you can see this is a whole data by the major registry. They show if patient is treated before 11 years, their normal lifespan is equivalent to normal. If treated before the 24 year, it's still 93% their survival, event-free survival. If between 25 to 41 years, it's still 84%. But after 41 years, you can see it's only 40% survival, 10-year survival. So you have to treat at the early stage to prevent complication. Other ASDs are like sinus venosus or coronary sinus ASD, or the IVC, SVC type ASD are the minor type. Another thing is the primum ASD. If you are on echocardiography, you are thinking this is a primum ASD, always check for the cleft of mitral valve leaflet, because primum ASD is always associated with the partial AV canal defect, and this is not a simple ASD. This is a whole syndrome, whole complex. Then you have to check for the mitral valve morphology, their cleft, their regurgitation, their whole anatomy, and also you have to check for the arrhythmias and ventricular dysfunction also. If any patient who is presenting with LA enlargement, in the case of ASD, always think about primum ASD. If axis deviation with ASD, think about the primum ASD or AV canal defect. Don't think about the secondum ASD or coronary sinus ASD. So this is a typical angiogram. You can see the gooseneck deformity in the primum ASD or AV canal defect due to disproportion of this length between the aorta to LV apex and mitral valve to LV apex. This is the typical angiogram for the diagnosis purpose of the gooseneck deformity for the AV canal defect. So any case of ASD where gooseneck deformity present, always think maybe primum ASD present along with the secondum ASD. And always think it's not necessary that ASD second is present. There will be no option. There will be no another ASD. Sometimes primum ASD can be associated with second ASD. Second ASD can be associated with the coronary sinus ASD or sinus venosus ASD. So for the REMS and ASD device closure, you have to think about the suitability of device. You have to check the REMS. What REMS are important? These are the superior, posterior, inferior, and AV valve. So you have to go from the 0 angle up to the 90 angle. So check all the size. 85 millimeter good rim is appropriate for the device closure. You can see this is all the rims. On echocardiography, this is the angles given, and you can see that the rims is good size rims, the IVC, SVC, aortic, and AV rims. So 3D now, 3D echocardiography, you can see easily diagnose the ASD, their position, their REMS, suitability for the device, and also you can see from the RA view, LA view, from the SVC view, IVC view, from all directions you can assess the suitability for the device. And on the 3D, you can also deploy the device, and it will give you the more accurate picture. So multiple devices are present nowadays, and they are the more flexible with advanced delivery system, advanced material, and they are more centrally placed. They are the more adjustable, and you can manipulate. So this is called the balloon-assisted deployment of the ASD or balloon occlusion test. So this is the ASD you can see. Other thing is the balloon occlusion of the ASD. If patient with a LV dysfunction or diastolic pressure is increased, you have to occlude the balloon, ASD with the balloon, and see the EDP. If EDP increase from baseline to double in number, means your LV is restricted. You have to fenestrate the ASD, or check whether you have to optimize the function, then close with ASD. So that is the VSD. VSD is basically most common cause of congenital heart disease, but less present in the adolescent or adulthood. If once present, it may be like a small VSD, or if presenting with a moderate to large size. So any type of VSD, you have to think whether it's presenting in the adolescent or the adulthood. check whether the patient is symptomatic or is asymptomatic. If asymptomatic, mostly is presenting with it due to murmur for the screening. So in adolescent or adult, if VSD is mostly presenting with the complication of aortic regurgitation, LVOT obstruction, RVOT obstruction, or moderate to large size VSD will be presented with the signs symptoms of heart failure and pulmonary hypertension. So we have to focus in adult and adolescent on the pulmonary hypertension and heart failure.
Sattar, you said that AST should be closed at least 2 million.
Yeah.
What about VSD?
So VSD is dependent upon the size of the VSD and clinical sign symptoms. A small VSD and no clinical sign symptoms, no complication, no aortic regurgitation, you have to just follow yearly. And if patient is developing like infective endocarditis, LVOT obstruction, RVOT obstruction, aortic regurgitation, or sign symptoms of heart failure, you have to close. Nowadays, most of the VSD you can close by percutaneous, like a perimembranous and all type of muscular VSD. Only the inlet VSD and supracrustal VSD are the exemption. Or if a patient is with a multiple disease like aortic regurgitation and surgery is indicated, then you have to go for the surgical closure. Like in our NSFD data, almost we are closing the all type of muscular VSD, perimembranous VSD. We have tried the supracrustal VSD, but in the supracrustal VSD, there is a high incidence of aortic regurgitation and heart block. That's why it's a relatively relative contraindication, not total contraindication. But if you are thinking the supracrustal VSD is away from the aortic valve and there is a 5 millimeter distance from the aortic valve, you can put the device. Nowadays, we have the multiple good type of multifunction occluders. They are very soft and cell-adjustable devices. You can put and you can see on the transesophageal, mostly 3D or 2D echo, the position of the VSD and whether it's a pinching to aortic valve or not pinching. Then you can release easily. So it's very simple. Now the advance and the technology show that VSD can be closed by the antegrade and retrograde, both ways, from the aorta and from the RV. Previously, up to the 2 years back, everyone was closing the VSD from the pulmonary artery to RV to aorta. But nowadays, recent devices is easily, and we can close by small French delivery system. We can go from the arterial side from aorta. So I prefer recently we have arranged the multifunction occluder. This is a very good, soft, adjustable device. It's going from the 5 French or 6 French delivery system. You can put easily the 5-6 French delivery system even in the newborns, neonates. So like previously, VSD was, is for indication that for the VSD you need the large delivery system, large catheter, and so devices was very bulky. And that was a relative contraindication that we have to wait for the weight of the patient at least 15 kilo. But nowadays we are closing at the 5 kilo and even sometime less than 5 kilo.
Dr. Abdul Sattar, I want to ask the question.
Yeah.
What is the update about VSRs who are routinely encountered in our daily practice? So any update about VSR closure in our setup or in other setups?
Yeah, for the VSR, we can close the VSR, but it depends upon the patient condition, its hemodynamics, and its margin of the VSD. Because in the during acute phase, margins are very friable, and so device can be easily dislodged. And it's depend upon the size of the VSD and location of the VSD. If it's more distal toward the apex, toward the moderator band, it's a less suitability, or more proximal toward the aorta is still less suitability for the device, because it will pinch whether the apex of the ventricle or to the aorta. So it's midway, and size is if like a 10 to 12 millimeter with good margin, we can close easily. Like last time we were trying to close, but patient was in the shock, and it's all the hemodynamics along with the septic parameter was positive. So we were waiting to decrease the septic parameter, but patient couldn't survive.
We are talking about VSR post-MI. The survival rate at NICVD is 0. But since the device exists, there must be people, fine, there must be very high mortality. I totally agree. You know, I don't know the numbers, could be a 70% mortality, whatever. But if you do 100, 30 should survive. So I think there is something wrong, that our technique is not right, or the device we're using, we don't know how to deploy the device, where exactly to deploy the device. See, my problem is that even our surgeons do not, their results are very, very unsuccessful also. Everybody they do, the patient dies. So I think we have to think about it. Where is Dr. Abdul Hakim? I think we have to think about it, and maybe VSR is such a thing that nobody is going to predict when it's going to come.
Yeah.
So if you go somewhere else, then also maybe they may or may not have a VSR patient coming in the week you go and try to learn. I think we just got to learn ourselves a lot of things. Look at the theory of it. Look at what is that we are doing wrong. But I think that's very important because we get so many patients of VSR here and none of them survives. That's very sad. We have to look at that.
So last time there were two patients arranged by Dr. Abdul Hakim and Dr. Jahangir. You can give the feedback. Two patients of VSR both presented in cardiogenic shock and multi-organ dysfunction, and one patient was on the intra-aortic balloon pump. So we even arranged all the material, device, everything we planned for and we were waiting because patient was septic, but he couldn't survive, I think, more than 48 hours. So other patient was not suitable for the device because his septum was whole perforated and multiple perforation with the up to the aortic valve.
See, there's another problem.
Yeah.
You put the device in and you close it.
Yeah.
And you think it's fine. Okay, slowly you come back to the echoes, but VSD comes back.
Yeah.
Because that VSD starts to not participation in the VSD.
Yeah.
And that is another problem that we need to learn about. I can't believe that everybody who gets a device dies.
So this is equivalent to VSR case. This is a mid-muscular VSD and this is an adolescent patient. So we did a device closure from the aortic root by a 7 French delivery system, and we deployed this VSD 18 millimeter VSD. So you can see it's between the near to apex. So this is like a VSR patient. So VSR is also this VSD is also mostly at the mid basal to mid, sometime to apical area. But the problem is that you can see this is the healthy septum. All the VSD is coming inside the pouch, and pouch is healthy, giving some retention disc and some support. But in the case of VSR, this pouch or this septum is not healthy. It is very friable. It will not give the all type of support, and LV is already with dysfunction and hyperdynamic. So this problem is, we know the problem with VSD, but also they depend upon the hemodynamics condition of the patient. So these are multiple cases of VSD. Even we have put the large ASD in the case of VSD, and sometimes the PDA device, VSD device, coils, and multiple other options. Other things is the PDA. PDA is still, you can see, is sometimes present in the adolescent and adulthood. If it's a small to moderate size and diagnosis under incidental finding by the murmur. And sometimes if VSD is large, hemodynamic disturbance, heart failure, cardiomegaly, and patient is presenting with the heart failure to different doctors and finally referred to for the cardiac evaluation. And there is a multi-type of PDA, but almost 90% type of PDA nowadays is a deviceable because of the multiple devices. We are using like a PDA device, ASD device, VSD device, and sometimes the coils in the PDAs. And also we are closing almost each type of PDA by the device. You can see the problem in adult is the differential cyanosis. If you are leaving the PDA unoperated, our patient is undiagnosed or diagnosed at late age and developing the pulmonary hypertension, it will cause the reversal of shunt at the PDA. So descending aorta will be supplied by the pulmonary artery because of the high PA pressure, and ascending aorta, upper limb by the ascending aorta. So upper limb will be pink, but lower limb will be cyanosed. So in case of PDA, you have if presenting in the adult or adolescent, then you have to think about the upper limb and lower limb saturation, and you have to check out the pulmonary hypertension. You can see PDA for the investigation point. The CT scan sometimes needed in the difficult cases where we are thinking the PDA morphology is abnormal or unusual. Otherwise, cath is sufficient for the deviceability, for the hemodynamics. The problem in the PDA is that if PA pressure is high and cardiac output is dependent upon the shunt, if you are closing the PDA by device, patient will deteriorate it and will develop the low cardiac output. For this type of scenario in adult, we have to occlude the PDA by device or by the balloon to see whether this shunt is providing the cardiac output or not. If by closing the this PDA by balloon, normal phenomena is there must be decrease in the PA pressure and increase in aortic pressure. But in case of severe pulmonary hypertension, if this shunt is obligatory and needed necessary for the cardiac output, patient will drop the aortic pressure and PA pressure will remain high or elevated. Means it's a shunt is obligatory, you cannot close the shunt. Other thing, sometimes a very large PDA, you cannot close with the PDA device. Like this case, very high volume hypertensive PDA, that was not deviceable, but we put the VSD device in this case. You can see there's a large VSD device in adult patient. It's very well placed, and patient is maintaining the aortic pressure and pulmonary artery pressure drop 20%. Other things like coils and a multi-type of devices are nowadays available. You can see this is the sizing for the PDA and balloon occlusion test. So other things, the pulmonary stenosis is also a common disease that is present in the adult or adolescent, and most of the time they are the asymptomatic. If a mild to moderate, whole life they are surviving without any signs symptoms. But in the case of severe pulmonary stenosis, they are causing the RV hypertension, RV dilatation, and RV dysfunction. So this patient who is with pulmonary stenosis, RV dysfunction is basically poor candidate, will develop the low cardiac output and all the right ventricular syndromes or RV ventricular dysfunction signs symptoms, and even after dilatation, this patient their survival is less as compared to normal population. So the main lesson is that if a patient with a pulmonary stenosis and RA-RV dilatation or dysfunction, even mild or sign symptoms are present, you have to balloon dilate. Even with moderate pulmonary stenosis with sign symptoms, we have to open the valve. So you can see the post-respiratory dilatation of pulmonary artery. So if it's a long-standing pulmonary stenosis, it will cause the pulmonary artery dilatation, pulmonary artery diseases and lung changes, even obliteration of the lungs and their parenchymal changes and RV dysfunction. So we have to treat the pulmonary stenosis at early age before the sign symptoms of heart failure or RV hypertension or RV hypertrophy. So it's a simple technique. Nowadays, very compliant balloons are available. We have to do the angiography and see the annulus. If annulus is like a 20 millimeter, we can go up to the 1.4 time, means 28 millimeter. But you have to start from the 1:1, then increase if according to your results. So other is the coarctation that is present in the adult or adolescent. This is also lifelong disease. Once it's appearing, the narrowing at the arch or descending aorta or abdominal aorta, it will be always progressive. So you have to check clinically and accurately what are the lower pulse volume in every patient who is present with the sign symptoms of heart failure or upper body hypertension. So any upper body hypertension can be due to coarctation or LV dysfunction, LV hypertrophy due to coarctation. Sometimes it's missed on the 2D echo. So you have to make practice to take the forward limb blood pressure in every case of hypertension. At least check the lower limb pulses. So any patient with coarctation and gradient is significant, then you have to check for the CT scan, MRI or echocardiography along with the cardiac catheterization. So on cardiac catheterization, if gradient is more than 20, then you have to check whether this portion is a balloon dilatable or stentable. Normal in the adult or adolescent patient who is more than 25 kilo, you can put the covered stent. And covered stent results are very excellent. It will prevent the long-term dissection, aneurysm formation, recoiling, and also prevent the long-standing hypertension and LV remodeling. You can see this is a significant coarctation along with so this is a CT scan. You can very critical coarctation. Even you cannot pass the wire. In this case, you have to perforate, you have to get access from the left or right carotid or radial. Then you can give the injection in the ascending aorta to delineate the orifice. They cross from the ascending aorta, simulate the wire, and put the stent. So these are the multiple stents nowadays available, mostly covered with excellent results. Their follow-up show that if you are correcting and treating the coarctation before the 20 years of age, its results are excellent as compared to patients who are treated after 20 years of life. Because the main issue is the aneurysm formation, arteriopathy, and a dissection. If even you are putting the stent or other surgery after 20 years of life, there are incidents of aneurysm formation, dissection, and persistent hypertension. So take-home lesson is that every type of congenital heart disease, who is misdiagnosed, underdiagnosed, or late present, if he is symptomatic or asymptomatic, at least enroll your system, do the proper investigation and proper management. You have to profile whether the patient needs the just intervention, surgery, or medical therapy, and treat the patient at early age. Like in our data shows, the NICVD Sattar Center had the all population who are presenting in the adult or adolescent were the unoperated or in advanced stage of disease. So once we have started the services at Sattar Center, we enrolled them, we started their medication, intervention, surgery. Nowadays, we have the less patient in our Sattar centers who are unoperated or in advanced stage. Mostly are the treated with the multimodalities team. So any question? Thank you.